Okay. Thank you, Ross.
All right, so I'll make a start then. So my name's Ross. I'm one of the ward pharmacists, and I'm currently on Clifford Ward, working in acute medicine. I'm just going to do a presentation today on time-critical medications because it's been noted that time-critical medications are being missed. So we just want to raise awareness of what these medications are. So first of all, let's just start by discussing what are time-critical medications. So they're medications that must never be delayed or omitted. So by delayed, we mean 2 hours later than when they were actually prescribed for. And by omitted, we mean not given at all. And why should we not be omitting or delaying these medications? Well, it's because if we do, then it's likely to result in a deterioration of the patient's health, and it'll probably also lead to a prolongation of their admission as well. So rather than actually focus on the medications first, I thought it'd be worthwhile focusing on the conditions that involve time-critical medications. So at least then these patients can be identified. So I'm just going to go through this list quickly. So we've got Parkinson's disease, epilepsy, any infections, whether that be bacterial or viral or fungal, psychosis or bipolar disorder, any venous thromboembolism, so PEs or DVTs, and atrial fibrillation as well when they're on prophylaxis for VTE. People that have had a mechanical valve replacement, people that have received an organ transplant, patients with diabetes or patients that are steroid dependent. So for example, people with Addison's disease, patients that have had a stroke or an MI in the past, or patients that are in severe pain. So if we can at least identify these patients and these conditions, then we can raise with the rest of the medical team if we think there's missing medications. So first medication type is antimicrobials. So these are for the treatment or prophylaxis of infections, like I said, caused by bacteria, viruses, or fungi. There's some examples there. I'm not going to go through all of them, but I'll just focus on some of the antivirals. So some of the antivirals listed on here are actually HIV medications. So the ones like tenofovir and emtricitabine, they're used in patients with HIV. So they definitely shouldn't be missed to make sure their viral load is kept down. And why are they time critical, these medications? Well, it's because if we don't give them, then there's likely to be a progression or development of the infection, which could lead to sepsis. And it also leads to antimicrobial resistance, and that can occur in all types of microbes, so bacteria, viruses, or fungi. So possible implications of missing these antimicrobials. Like I said, you can have an infection that progresses to sepsis. That sepsis could then cause organ failure, and that could then lead to permanent kidney damage for the patient. Or bacteria could develop a resistance to an antibiotic, which then leads to us having to use second or third line agents instead. The reason we don't like to use these second or third line agents, is that one, they don't always work as well. Two, they can have an increased risk of side effects. So things like coamoxiclav, cephalosporins, they have an increased risk of giving the patient C. difficile. So obviously we don't like to use those if we can avoid them. Next is antiepileptics. So these are used for the prevention and treatment of seizures, whether that be in epilepsy or non-epileptic seizures. Some examples here. I've also listed the brand names for these medications because sometimes they're prescribed by brand, and that's for a reason. They should be kept on the same brand where possible because they have different release profiles and different therapeutic effects. Particularly ones like phenytoin, primidone, and carbamazepine, they should be kept brand specific where possible. And why are they time critical? Because they have an increased risk of seizure activity, including possibly fatal status epilepticus if they're not given their antiepileptics on time. So possible implications, we have a patient that's had their seizure threshold lowered and they go into status epilepticus, which is a medical emergency, and that could lead to permanent brain damage. And as I said before, that can also be fatal in some cases. Anti-Parkinsonian drugs are next. So they're for the treatment of Parkinson's disease, and they are to lessen the symptoms and slow disease progression. Examples are here as well. I've listed the brands as well. So Sinemet is co-caroldopa, Madopar is cobeneldopa. Patients that are nil by mouth can be put on rotigotine patches. And then there's Sagaline, Rapinol, Pramipexole. There's other ones as well, but obviously this list is not exhaustive. I'm just trying to raise awareness of the most common ones that we tend to see. Why are these time critical? So if we don't get them on time or if we miss them, there can be an exacerbation of the patient's symptoms. So this could be a tremor, it could be dysphasia, it could be dysphagia, rigidity, incontinence, and they're also at increased risk of falls when these symptoms start to be exacerbated, and we can also see a disease progression as well. I'd just like to raise awareness as well that Parkinson's drugs should be given at the specified time. So these might not always be the times that our drug rounds are done. This should be confirmed with the patients or their carers. Usually as pharmacists, we try and do this, but if possible beforehand, if the nurses could try and confirm it, that would be brilliant. And then they can get the prescribers to actually change the times and make sure these are given at the correct time. If they're not given at the time specified, that can also lead to exacerbation of symptoms as well. So it's really important that we give them at the times patients usually have them at home. Possible implications of missing anti-Parkinsonian drugs. So we can have a patient that's got an onset of symptoms, which includes rigidity. Then that patient is unable to mobilise, and then their discharge is delayed because PT and OT are unable to assess them for an extended period of time. We could see a worsening of the patient's symptoms, and then they develop a swallowing difficulty. And then that means that oral medications have to be switched to alternative formulations, which means that doctors are having to use more time up to do that. Pharmacists are probably going to have to intervene as well and use up their time as well. Obviously, I think we all understand that everyone's time at the moment is precious. So if we can avoid any of these things, it'd be brilliant. Anticoagulants and antiplatelets. So these are used to prevent and treat blood clots in those with a history of VTE or those with an increased risk of VTE, such as those with atrial fibrillation, mechanical valve replacements, patients with antiphospholipid syndrome. And then antiplatelets are used for treatment and prevention of myocardial infarctions or strokes or TIAs. So some examples here: warfarin, probably the most well-known one. DOACs, which we normally see apixaban used in this trust most often. Low molecular weight heparins, so our low molecular weight heparin of choice in the trust is enoxaparin, but we might also see dalteparin being used sometimes. And then antiplatelets as well at the bottom. So why are these time critical? If they're not given, there's an increased risk of that patient developing a clot, which can then lead to VTE or a stroke or a myocardial infarction. So a possible implication here is that the patient develops a thrombus. That thrombus then leads to a myocardial infarction. That patient then has a prolonged stay in hospital due to that heart attack that they've had, and then end up leaving the hospital on a lot more medications than they came in with. Antipsychotics are used for the management of psychosis. So these can include schizophrenia or bipolar disorder. Some examples of critical ones here are clozapine, lithium, quetiapine, olanzapine, and risperidone. Clozapine, I'd just like to bring to attention here that if a patient misses, I believe it's 3 days of clozapine, then they need to be retitrated again. So that's quite obvious why that's time critical, because if they miss a few days of that, then it means that they have to start from scratch with the dose again. Why are these time critical? Well, it can lead to a relapse of the disease, agitation in the patient, and like I said, for clozapine, retitration of the drug. So a possible implication here for antipsychotics is that the patient relapses and has an episode of psychosis. That patient then becomes paranoid and refuses to take any of their other medications. And then that leads to us having to actually section the patient under the Mental Health Act to ensure that they're given the medication. Analgesics, so these are painkillers and they're used for the treatment of pain. There's obviously quite a wide variety of painkillers that we use. So Opioids are probably the most critical ones, but we also have paracetamol and non-steroidal anti-inflammatory drugs as well. I've just highlighted methadone there on the right because methadone is not normally given for analgesia, but it is an opioid. It's actually normally given for controlled opioid withdrawal, so in patients who have a history of IV drug use. The dose should be confirmed before administration. So please make sure that when a patient is on methadone or is known to be taking methadone, can we liaise with S2S? That's the Substance Misuse Service used locally. And can we also liaise with pharmacy as well? Just because we've had instances in the past where patients have missed several days of methadone, which would require retitration from a lower dose, and then they've been actually given the dose that they were previously taking, so quite a high dose, and that's then led to patients becoming drowsy, opioid toxicity, and then that's led to prolonged admission. So why are these time critical? Well, patients are in increased pain if they're not given these medications, which can lead to confusion. It's obviously not very pleasant at all to be in increased pain. And with opioids particularly, there's a risk of that patient then becoming opioid naive. That means that they're not used to the level of opioid that they were receiving, and then we can give them a high dose, which they were possibly previously on, and that then increases their risk of being overdosed on the opioid. So a possible implication is that the patient's pain is uncontrolled. They, as a result of that, experience poor patient healthcare, and then this leads to a development of the patient distrusting healthcare professionals in the future. So obviously that's damaged their relationship with healthcare entirely because of that. Immunosuppressants are used for the prevention of transplant rejection, usually. These may be held in severe infections. Just I'd like to raise awareness of that because there might be a reason it's been stopped, but that needs to be confirmed before we withhold them. And this is usually on specialist advice only as well. So normally renal team if it's a kidney transplant, cardiology if it's a heart transplant, for example. Examples of these are cyclosporin, tacrolimus, mycophenolate, and prednisolone, which is a steroid. And why are these time critical? Well, without the patients receiving them, there are an increased risk of transplant rejection. So a possible implication here is a kidney transplant rejection occurs as a result of them not having their immunosuppressant medication. That patient then requires surgical removal of their transplanted kidney, and they then have to go back onto hemodialysis 3 times a week for renal replacement therapy. That's obviously a massive impact on that patient's life, having to go back onto hemodialysis. They'll probably have to go back onto the transplant list, which means that an organ has just been wasted. Insulins and other hypoglycemic agents. These are medications used in diabetic patients to lower their blood glucose. So there's quite a lot of insulins I've listed on here. These are the brand names for insulins. Insulins should always be prescribed by brand. They should be prescribed by device as well. And the strength should normally be written as well for the insulin. We need to confirm the doses with the patients as well or their carers. I think it's quite obvious that if we don't give the right dose, then that patient's blood glucose isn't going to be controlled correctly. That could lead to hypo or hyperglycemia, which themselves have their own complications involved with them. Some other anti-diabetic agents which are oral include metformin, gliclazide, dapagliflozin, linagliptin and sitagliptin. I've forgotten to write on here as well, but there's also the GLP antagonists. So these are also injectables. These are things like semaglutide and liraglutide, which should also be prescribed by brand. So possible implications of missing these medications are hyperglycemia, so where their blood glucose has been raised. That can lead to diabetic retinopathy, so damage to their eyes, and that patient's vision then deteriorates, and that patient can no longer drive as a result of their vision becoming worse. In hypoglycemia, we can see the patient's blood sugar drop so low that they actually go into a diabetic coma. and then it results in a greatly prolonged hospital stay and recovery period for that patient. Corticosteroids are next. So these medications have many uses throughout healthcare. They can be used for treatment of inflammatory diseases, hormonal deficiencies, and as we've said previously, for immunosuppressant therapy. Some examples of these are prednisolone, dexamethasone, which we're seeing quite a lot at the moment with COVID patients, hydrocortisone and budesonide as well. And why are these time critical? So we can see worsened disease states in the patients requiring them. And in patients that are steroid dependent, it can actually lead to an Addisonian crisis, which is a life-threatening condition. So just an example of a possible implication here, the patient has an acute adrenal crisis. So they actually have insufficient cortisol levels, which is the endogenous, so the natural steroid that the body produces. That leads to them having low blood pressure, severe dehydration. It can lead to organ failure and even comas. And it can actually lead to fatality in extreme cases as well. So that's the medications covered. It's not an exhaustive list, but it's the sort of the key ones that we see in the hospital. Just want to highlight some issues with time critical medications as well. So patients being nil by mouth or unconscious isn't usually a reason to omit or delay oral time critical medications. In these cases, before omitting or delaying the doses, can we please raise this with the patient's doctor and, if possible, discuss it with a pharmacist as well for alternative choices or to decide whether it can actually be stopped. If you notice that someone has delayed or omitted a dose, which is time critical, please can we Datix it? Don't see Datixing as a way of reporting someone and sort of telling on them. Datixes are done for a reason. They're done so that we can learn from errors that have been made. And then this learning can also be shared with others to prevent them happening again in the future. We're not trying to catch people out by submitting Datixes. It's just done so that we can reduce the risk for patients in the future. How can we avoid missing critical medications? So hand over to colleagues where possible. So if you know that a patient's on a time critical medication, when you're handing over to your colleague at the end of a shift, just raise that that patient is on a time critical medication with that colleague. If you're unsure about anything, be that a medication, it's the way it's being given, if it should be omitted or delayed because you think something is wrong, please discuss that with either a senior colleague, the patient's medical team, so their doctors, or a pharmacist if they're available on the ward at the time. And how can we source time critical medications? So during pharmacy opening hours, so between 9 and 6:30 Monday to Friday and 9 and 12:30 on a Saturday, we can check the patient's drawers first of all to see if the medication's been brought in from home. Failing that, if you check your ward stock list, see if it's stocked on your ward, and then go and take it from the ward stock and place it in the patient's drawer for use. And then failing that, if the pharmacist is on the ward, have a word with them, or if there's a pharmacist covering your ward remotely, just give them a bleep and discuss it with the pharmacist, and you can place an order with them to get it ordered. Out of hours, so outside of those opening hours that I've just listed, and on a Sunday when pharmacy is closed, if you check your ward stock list, first of all, you can then borrow from the ward stock or emergency drug cupboard. So I'm going to explain in a moment just how we can actually check if something is kept as ward stock elsewhere or in the emergency drug cupboard. And then failing that, in an emergency, which I've just realised I've spelt wrong, in an emergency, if you ring the emergency on-call pharmacist, they can then discuss with you further how to actually make sure that medication is obtained for the patient. So how do we access the ward medication stock lists? So these are available on KNet, under the medicines management section on KNet. So that's on the left-hand side of the screen on KNet, this blue section here. I'm not sure if you can see my mouse. the medicines management section is just down here towards the bottom, which I've highlighted. If you click on that, that will take you through to the medicines management page, which then you press the ward medicines stock list button on, and that then opens the ward medication stock list. When you get onto the ward medication stock list, if you press Control and F at the same time, that'll bring up the search function, and that allows you to search for specific medications. So if you type in the medication that you're after, that will then scroll to the part of the screen where the medication is, and you can then see which wards keep that as ward stock, and it will also say emergency drug cupboard as well if it's kept in the emergency drug cupboard in pharmacy. The emergency drug cupboard is kept in the out of hours room in pharmacy. I've just included the picture here of it for you. This is what it looks like. What you need is the patient's details to access the drug cupboard. It'll prompt you to actually put in the patient's details before you can take anything from it. There are instructions for using the emergency drug cupboard, which are kept just to the right of the emergency drug cupboard. There's a laminated sort of paper booklet which has a step-by-step instruction list for using it. It contains time critical medications and other sort of urgent medications which are not stocked generally on wards, and they're to be used in emergencies. And like I said before, you require the patient's details to actually access those. So before you come down to pharmacy, make sure you've got the details, the medication that you're needing, and the patient's hospital number, name, etc., to input that in. Okay, so that's everything that I'd like to cover. But if anybody has any questions or feels there's anything that I've not covered, please feel free to ask now.